I'm really excited about the two speakers that we are going to have in our breakout session. It's a real treat for me, who knows both of our presenters, to hear them speak because the topics that they speak about are really germane to not just Fargo, but to our broader community here in North Dakota, northern Minnesota, South Dakota, et cetera. So today we're going to have a great presentation from Dr. Karen Lloyd. I had introduced her before we had our breakout session. And she's going to talk about a little known risk that currently affects productivity in the workplace, affects community health at large. Study after study is revealing a serious new public health risk, rivaling, as I mentioned, obesity and smoking. British Prime Minister Teresa May even appointed a minister to fight it. At work, it threatens productivity, engagement, and raises costs. Today, Dr. Lloyd will share how to best recognize this insidious condition, understand how it impacts health, and hear from her practical advice on what you and your team can do to prevent it. Karen.
Thank you. Thank you, Mark. Really appreciate it. Oops, I hope I did fine. So this is a little known risk factor, but I want to show you the agenda. I always like to know what my speakers are going to talk about. So welcome, and I'm going to ask a question. We're going to talk about this little known risk factor and its impact on health, on well-being. We're going to do a couple little 1 or 2 minute things, like an exercise, a couple of questions. And then we're going to turn very practical. What you can do to combat this little known risk factor in the workplace. And at the end, we'll select an action item. So, what is the most potent driver of premature death? I'd like to see a show of hands. Smoking? Physical inactivity? Obesity? Yep. Alcohol abuse? Loneliness? It's loneliness. My colleague and friend, Jim Epple, may have given it away earlier in his talk, but I was trying to be very mysterious about this. So I'm glad you came anyway, and I hope others join us. I know you can't totally read this, but the farther the bar is over to the right, that means it contributes more to early mortality, early death. So right at the top, that's social connectedness. Down further is smoking. Down further yet is alcohol abuse. And when I say alcohol abuse, that's 6 drinks every day. That's a lot. Further down, physical inactivity, and look where obesity is, kind of down to the bottom. So this is just not being worked on the same way as some of these other modifiable risk factors. So bottom line, loneliness is as lethal as smoking 15 cigarettes a day. Did all of you know that? Did anybody know that? Oh, good. Oh, Jim, and he's sharing. But it underlies real problems with being able to be healthy and have high well-being and being productive. It really is corrosive. So we think about these things as the modifiable risk factors, and many of you are working with your employees on them. But what is the bigger thing? It's really social connectedness. Not that we should let the others go, but what is the scale of the issue? It's called epidemic. 3 out of 4 adults say they feel lonely. 54% of them moderately lonely. 22% of adults describe themselves as highly lonely. And you can't tell by looking. Sometimes people are not socially isolated. They can be right in the middle of lots of people. So it's what people feel on the inside. So loneliness and isolation at work really matters too, because they're really strong, lots of evidence showing the physical health consequences. And I'll show you some of that. The mental health research is a little harder to tease out because loneliness or social isolation is a part of depression, for instance. It's a symptom. But there is good research to say it's associated with. And performance on the job, there's a lot of strong research saying that people that are lonely are not productive as much, and actually they move on from jobs. But the good news is, and there's a lot of good news in this presentation, there are lots of ways to become less lonely as an individual and to help your workforce have less experience of loneliness on the job. First, I'm going to do research, then we'll turn to the practical ways to implement things. So the numbers, loneliness increases the chance of premature death by 26%. That's huge. 33% of adults over 45 are chronically lonely. Loneliness is associated with a 32% increase in the risk of having a stroke. 1 in 5 American students is bullied. And suicide is the second leading cause of death for Americans aged 10 to 14, 15 to 24, and 25 to 34. It's pretty shocking stuff. I did a lot of research reading in order to provide this presentation. And down in the bottom, in pale gray and tiny font, all my references are. So just want to let you know that if you call me on this, I can't tell you, but if I could read that font, I would tell you where I got it. So the loneliest periods and the loneliest people, loneliness really peaks among the young and also the old. So ask, do you often or very often feel lonely? 40% of 16 to 24-year-olds would say yes. Often or very often. And then we go to the 65 to 74 at 29% saying yes, and 27% over 75 years. So it's a bimodal distribution. And the very loneliest people, on average, are single or single living with their minor children. And either they live alone or with their children, and they are low income. They have incomes of less than $35,000. Now here is some data about HealthPartners members. And it's interesting because we took a sample and got 3,500 surveys back during a part of 2015 and part of 2016. We asked on a scale of 1 to 10, how lonely do you feel in your daily life? And higher scores mean more lonely. The females that responded reported greater loneliness than males. The 18 to 24-year-old age band had the greatest loneliest scores compared to any other age. And the type of coverage counts too. The commercial were among the least lonely, Medicare was in the middle, and Medicaid were the most lonely. And so this slide really does reflect the same thing we saw at published research. There's a paradox in loneliness, and you probably all know this. Sometimes we're alone and we don't feel lonely. Other times we're with a crowd, but we still feel lonely. And in our culture, it's very hard to admit to yourself or to others that you're lonely. Who wants to kind of fess up and say, I'm not very popular, I'm lonely? We don't. And the experience of loneliness is different for different people. We can't imagine that it's the same for everyone. And it's also different across our own lifetime. The loneliness you felt when you were 22 is not the loneliness that you might feel at 40 and may not be the loneliness you feel at 16. So it changes over time. So here's the questions. So this is yes or no. I want to see hands. Do only your close relationships help protect your health, well-being, and productivity? Yes? No? No, you guys are smart. How about this? If you're having difficult or conflictual relationships, does that impair your health, well-being, and productivity? Yes? No? Well, I know you don't get the benefit. I've read all of the research that's relevant. You wouldn't be getting a boost in your health and well-being and productivity. I haven't gone into deeply into the conflictual relationships to see if it actually takes you down below what just kind of lonely people have. But I suspect so. I may look into that for next year. So here's a question. Since I have a lot of social connections, can I keep or even add to my own bad habits? Yes? Couple, I got no, people, no. It's really not. That's not the point here. I'm going to take like a minute and a half, and this is a little tedious for some of you, but I think I'd like you to understand how researchers, and they're mostly psychologists like me, how they think about social factors and their impact on health and well-being. So this first one over to the left, social cultural conditions, that's like the culture you live in. So it's the culture with its norms and values, socioeconomic factors like whether you are privileged or discriminated against, geographic factors, urban versus rural makes a difference, and social change, like back when we were in the big recession that we've finally come out of, that makes a difference. Then the next column, the social networks, that's your own personal social networks. And it depends on the individual, the size and proximity of your network, and reciprocity. For instance, if you're a piano teacher and you teach 10-year-olds, while that's kind of social, it's not reciprocal because you're teaching the child is not being social and giving you something back. So the reciprocity and your social ranking. In your network, you might be at the middle of the network because you know everybody in the network, and therefore you're kind of at the middle because you've got all those connections. On the other hand, if you newly moved into town or changed schools or something, you might be on the periphery. You'll only know one or two people in this social network. So that's what your social ranking is about. If you're at the center with lots of connections, you're highly ranked. And if you're on the outside, just kind of learning and making relationships with people, that's a low ranking in that network. Your network activation, the frequency with which you have face-to-face contact with the people that are in your social network counts, and also the non-visual contact, the texting or the letters or the phone calls. The durations of your relationships and the intensity of your relationships, whether you share a lot in common or a little bit. So then I'm going to the next column, and this is a column, the supports and resources that mediates. So this impacts the social factors and how they are relevant for health and well-being. So the social support, whether your contacts are supportive or your network is supportive or there's a lot of conflict in it. Your access to material goods like jobs and healthcare and housing makes a difference. Whether you have meaningful social roles and you're socially engaged and interpersonally attached with more people or attached more firmly. And then the social influence is an interesting one because people in your network influence your choices regarding your health options, like drinking and smoking and exercise, and also your attitudes for seeking help. The last column is the outcomes. And the psychobiology or psychobiological pathway is your stress response, your immune system functioning, cardiovascular reactivity. And then the health behaviors, of course, is like the smoking, alcohol use, diet, exercise. Your psychosocial pathways, that includes your coping skills and your stress management techniques and how good you are at them. So that's kind of how a researcher looks at this issue. Now this is difficult. I have several slides that have difficult information on them. One of them was about the suicide as the second leading cause of death for young up to, I think it was 26-year-olds. The first leading cause of death is accidental, and usually it's autoimmune. But this set of research is really showing that white people, especially those with high school or less education, they are the ones spiking the U.S. mortality rates. and they're dying by drugs, alcohol, and suicide. And they may be part of your workforce. Almost all employers have at least some. Sometimes it's the majority of your workforce. And these people with low education, white people, may be especially vulnerable because they may be impacted personally or through their families or their social networks. So just wanted you to know that. I know these slides are small, but this is all-cause mortality for low education Black non-Hispanics compared to white non-Hispanics. So if you look at this, those are age bands. Each of them is 4 years, so it starts at 25 to 29, down, it ends at 50 to 54 years old. But in each of these cases, the Black people are the blue line, and the white people is the dotted red line. So overall, over time, Black early death has been going down, mainly, and white has been going up pretty remarkably. And here's what it looks like when you take those white, low education Americans and compare them across several other countries: Germany, France, Sweden, Canada, and Australia, and UK. And everybody else is kind of trending downward. And we, when we look at just the white people with low education, spiking. And in fact, that spike is enough to make our whole US mortality look different from the rest of the world. United Kingdom is taking this very seriously, and this is the cover of an 80-page document they published back in October of 2018. And it's really good. It's got research and strategy and structure on how to do things to promote social engagement and decrease loneliness. And they're using most of their government ministries and community empowerment. So this is a document out of that. So if you want to get that, this document, just Google the Connected Society UK, and it'll pop right up in it. They want to share it. And this is a document out of it. And this is kind of like the river of life. And the statement that loneliness doesn't discriminate, and the graphic really shows certain life events can make individuals more prone to loneliness. So like getting bullied in school, changing where you live, losing a job, entering a period of bad health, caring for a loved one. All of those can be an opportunity to really ratchet up your loneliness. Death of a loved one, having your kids move out and you've got an empty nest. So when you think about your workforce, among your workforce, there are people going through all of these kinds of things. So one of the things this tells me is that we're all vulnerable. Maybe not all at the same time, but depending on where we are in our life. So United Kingdom named Minister on Loneliness. Her name is Tracy Crouch. She's Undersecretary for Sport and Civil Society. I think we need one of these. I'm volunteering, but nobody's taken me up on it. The power of friendship. The positive thing is having close friends is very beneficial to your health, and we want to promote that kind of thing. So people with few social ties, nearly twice the risk of dying of heart disease. That's huge. Also, people with few social ties, they're twice as likely to get the common cold, even though they're not in touch with very many people. So it's that immune system functioning. When we're not connected, our immune systems are not working appropriately. So I want you to take the piece of paper that was on your chair, and we'll take literally 2 minutes or less on this. And I've got a little timer down here. This is on this side where it shows like a target. I want you to think about this. This is you in the center, and with you, you've got your spouse and your kids and your parents. And then outside of that is people you can call at 3 o'clock in the morning if you need to. Then your close relationships, then casual friends and coworkers, acquaintances, your affiliates. Your affiliates are people you don't know, but you have something in common. So if you met them at a cocktail party or something, you would immediately have things to talk about. Maybe they graduated from the same college as you, or they love golf like you do. So you have an affiliation, a common interest. So go ahead and mark on there, put initials of people in those different bands, and we'll take 2 minutes or less. Go ahead and mark. Okay, that's about 90 seconds. And I'd like you to consider strongly working on this later. This will tell you a lot about your social network as it is and whether you want to work on it a little bit. So we're going to use this page in a few minutes, so we can put it away now for a minute. I know you're not supposed to read your slides, but here I go. I'm going to read this slide. The impact of loneliness in the workplace. Quote, we are more connected than ever, but loneliness is epidemic. Work is part of the problem. Now it must be part of the solution. This fellow is Vivek Murthy. He's a physician, and he was the U.S. Surgeon General from 2014 to 2017. And that's his quote. In the UK, they have put a cost to employers of loneliness. So in the green, this is the loneliness. And to keep it simple, they just diagrammed it out. The red is health outcomes. So people that are more lonely have poor employee health. And then over into the blue, therefore they miss more days of work from sickness. Back to the red, they also have poor relative health, or their dependents are less healthy. And over into the blue, they lose more days to helping those relatives and children. Loneliness again, and then we're going down into the yellow, well-being outcomes. Lower employee well-being leads to, in the blue, lower productivity and lower staff retention. This is based on tons and tons of research. This is really true. And in the UK, because they're taking it seriously, they had their financial people identify a cost to UK employers. So they took those 4 cost drivers, the increased work days lost to sickness and lost to caregiving for immediate relatives, and the decreased productivity of the employee and decreased staff retention. And they came up with $2.5 billion, which is attributable to employer excess cost. And they said 2.1 billion is in the private sector in England. I went out, because this was published in October of 2017, and looked at the exchange rate. And if you just converted that 2.2 billion pounds to dollars, it's $3.3 billion. But then I thought about it a minute. And the whole of England is about the size of the state of Minnesota. And I thought, well, let's look nationally. So I went to 2017 populations. Our nation has about 5 times as many people. So I just took that pounds to dollars and multiplied by 5. So an estimate is $16.5 billion of excess cost goes to employers in the U.S. because of this really unrecognized issue of loneliness. So it's big. A lot of you are HR professionals, I think, or consulting houses, and you probably know about this. Having a best friend at work is really, really important. And just 30% of employees have a best friend at work. 7 times more likely, those that have the best friend, 7 times more likely to be highly engaged in their jobs. They're better at customer service. They provide higher quality work. They have greater well-being, and they're less likely to be injured on the job. All of this is out of research. And those without a best friend at work have just a 1 in 12 chance of being engaged with their employment. So that's an important thing to remember too. Researchers are starting to say that we are hardwired to be socially connected, that it's in our DNA, and they're starting to talk about the need for social interaction to be like food and water, necessary. And one of the things in reading all of this research, I printed things out. I killed a couple trees. I had about this much research. People have expectations about particular situations. So if you're going to the grocery store, unless you live in the big city and you're going to the corner grocery or a small town where you kind of know everyone, most of us just go to Cubs or wherever, and we're on a mission to get our groceries. We don't think it's going to be a social experience. And that's okay. We don't feel lonely in that situation. But if you're working on a team at your employer and they're saying, we've got to do this together, and to get best outcomes, our team needs to be strong and collaborative, and you don't feel any social connection with them, that is kind of glaring. People do notice that. And as I said earlier, loneliness in the U.S., I think, is particularly stigmatized. We're such an individual independence kind of nation. And masking your feelings of loneliness takes effort. And that's what researchers are suggesting. It's not proven yet, but I suspect in the next year or two we'll get more research on it. They're suggesting that masking of kind of being outside, an outsider even on your own team, that masking effort takes time and attention, and it drains you, and it interferes with task completion, team contributions, and your role relationships. Makes sense to me, but that's not demonstrated yet. They're suggesting it. So how do we solve loneliness at work? More happy hours, more lunches, more ping pong tables? Well, not that I'm against those kinds of things, but this is a professor from Yale, and she said, no, that's not really it. We need to create higher quality interactions between people at work. We need to set expectations. We need to practice this as leaders, and then we need to discuss the importance of treating each other well, like respectful listening, assuming good intent, taking the perspective of others, increasing trust by sharing information as pertinent, and maybe doing shared problem solving. These are the kinds of things that make people feel included and that really builds up that social connection. Loneliness is contagious, and it spreads through social networks, both at home and at work. People on the periphery, as I was explaining to you earlier, have fewer connections, and sometimes they're wanting to come in. They might be new on the job or new to the neighborhood. Sometimes they're being kind of blocked, so they're not being invited to all the parties, just maybe with 1 or 2 of the people. And sometimes these people on the periphery of the social networks, they feel really rejected and lonely. And they transmit those kinds of feelings and statements to that social network, and that can move through a social network. Others can kind of catch this, bad attitude. And this is the one sentence I'm really proud of. Most of this is just research and me summarizing research for you. The social fabric really does unravel from the outer edges. And that's because people that are not being let in or they're actively leaving, they're sending loneliness messages. And those signals can provoke Others, some of them that are in a vulnerable life stage, like that river of life, can provoke them to feel lonely. The good news is kindness and social connection is also very contagious. So this is a randomized controlled design experiment with 111 employees at a bottling plant, Coca-Cola bottling plant specifically. And they divided them up and had the employees go into 3 groups, randomly assigned. So there were the givers, the receivers, and the controls. The receivers were asked, create a list of ways that others at work could be kind. And on the list they created, and each person created their own, it was things like, say good morning to me, smile at me, wish me a good day, ask about my kids. At the end of the day, wish me a good evening. Now, the givers were asked to practice 5 acts of kindness per week toward the receivers. So the givers knew who they were, the receivers knew who they were. The controls knew nothing. They were left out of it entirely. So the outcomes are that both the givers and the receivers had short-term and long-term gains. The short-term gains were about the same for each of the givers and receivers. They were feeling more competent and more autonomous at work. And a lot of times, autonomy at work is something everybody works for and craves. The longer-term gains were measured at 2 months. Receivers were happier. They're the ones that were receiving the kindness. The givers had more satisfaction in their lives and on the job. And unexpectedly, the givers actually emulated, the givers' kindness inspired more kindness from those that were receiving. So people that were just to receive kindness started giving kindness, and they displayed 278% more acts of kindness than the controls that didn't know what was going on. That's powerful, and that's research showing that kindness is contagious. I'm going to do my second bad thing and read a slide to you, so hold on a minute here. So what kinds of workplace interactions work? This is from the Harvard Business Review. I'm typing this in a nearly silent co-working space. All of us here at Harvard Business Review are intently focused on our computer screens. The tap-tap of our fingers on the keyboards, the occasional rustle of paper, clink of a coffee mug landing on a desk are the sounds of our work. Look into the screens, however, and you will often see a noisy, sometimes a raucous place. We are commenting on news stories, we're checking on projects, and we're sharing photos of kids and cats. Is that kind of interaction enough? I don't think it's totally enough, but I think it goes a long way. And now we have more workforces that are more distributed over places, geographies. More people are working from home. You have plants in several different states. But this kind of thing can help. This is Dr. Vivek Murthy again. We saw him before, U.S. Surgeon General. When he went into office, he had to assemble a team. And at his staff meetings, he included 5 minutes for sharing personally meaningful photos. He named it the Inside Scoop. So people could decide what they wanted to show, the cat, the kids, my last vacation, my next vacation. He said it fostered comfortable staff interactions and helped promote teamwork. So it was a quick way to get all these strangers together, know a little bit about each other, and prep them for working together. Here's what HealthPartners is doing. We are starting a conversation with our 27,000 employees about the importance of loneliness and how to combat it. And that diagram, I know you can't read it, but that is our Be Well framework. That's our health and well-being framework for our own employees. So it's physical, community, emotional and mental, social and interpersonal, financial, career, and in the middle, finding meaning and purpose through healthy living each day in a way that is consistent with your values and beliefs. So we're using the Be Well model to communicate about this and start this conversation with our own employees. We're piloting the Unlonely project. The Unlonely Project uses art and technology to promote social engagement and inclusion. And it was designed to help improve health and well-being through that social engagement. It was developed by Dr. Jeremy Noble. He's a board-certified internist and preventive medicine doc, and he also has master's degrees in epidemiology and in health policy from Harvard School of Public Health. He serves on Harvard faculty now, and he's in the Department of Global Health and Social Medicine. That's social medicine. One thing, in the UK, doctors in the National Health Service are prescribing, so they're doing social prescribing. They're asking you, activate that network. It will be good for you. So anyway, I'm going to show you the Unlonely Project here in a minute. But how does it work? It's a website, and they have competitions. People send in films about what their social connections mean. And those films, they go from like 4 minutes up to maybe 20 minutes long. They're judged. The best ones are displayed on the website. And what you do to use this is you watch the films, and then they're curated, so they're in different categories. So there's one on campus life, there's one for veterans, there's one for caregivers. So you can kind of find things that might be relevant to you. Then what you do is there are reflective questions with each of the films, kind of like, what did it mean to you? What did you get out of it? What surprised you? That kind of thing. And then the last step of the watch, do, share is to send a link to those films to somebody you think it would be pertinent to family or friends or neighbors or even a community group. This is a public website, it's free. Everybody can go to it. You could check that out. But first I want to have you watch a film. It's called Agent of Connection. This is just one of the many. I think there are about 60 films out there. And they have other things that I haven't even looked at. They have playlists and other reading materials. I just look at the films. So let's watch The Agent of Connection. It's going to be 4 minutes long, and I think you're going to like this.
Good night. Hello, young lady. Enjoy your weekend, my love. What's up, brother? Got it? Have a good night.
Thank you.
Enjoy. Lumberjack. Good to see you, brother. Hello, sir. Step right up.
This job as a station agent is something I feel like I was born to do.
BART's Bay Area Rapid Transit.
It's the subway system here in the Bay Area. I've been working at BART for 20 years. I've chosen to live out of the area. A decision I made in '99 so my daughter could go to a public school that's blocks away from the house. That was a sacrifice. It's a 2-hour commute, each direction. Growing up, I felt like I was in a box where I was separated from other people. I was very shy and withdrawn, and I had a speech impediment. People were engaging and moving about and living a life, and I was an observer, and I didn't like that feeling. Being in a booth reminds me of that feeling. You know, I don't want to be the person who separates themselves from life. It took me a while to realize that part of being in that situation is self-imposed. If you're in a corner or in a box, it's not necessarily because someone put you there, it's because you've agreed to be in that box. Once you realize that no one put you there, you put yourself there, that you're responsible to come out of the box, everything starts to change. And when I see other people who may be in that situation where they feel like they don't belong, I feel responsible to show them that they do. Every day that I come to work, I engage with 4,000 people. I speak to them, I say hello, I invite them in, I give them good graces going out, I fist bump, I shake hands. People that I've established a relationship with, I hug. I'm not a booth troll, I stay outside. That's where the people are. People look at the BART agent and they think, well, all you need is a high school diploma to be an agent. But no, they tested 5,000 people in the Bay Area. And of those 5,000 people, they interviewed 100. And of that 100 people, they hired 30. And I'm one of those people. I went to Berkeley. I was accomplished. I had my own business for 7 years. It's a fantastic thing. Being able to look out and see the world as it is. The homeless, the hurt, the happy, the focus, the different walks of life that I engage in is all beautiful. I'm happy to be a part of it. Stepping forward and saying hello to someone and occupying someone else's space and learning about that person is the easiest and the best thing in the world. I could do this every day.
Have a wonderful night. Big plans?
So, the films are as different from one another as you could possibly imagine. If you want, you can go out, and if you Google the Unlonely Project, it'll take you to this website. The website has a different name, but Unlonely Project is what you want to Google. So now I have a call to action. So with the sheet, we've prepared on the opposite side from the target. There are a number of things listed here that you could do, one of them or more of them, in the work site. And these are pretty simple, straightforward things, and it doesn't take, a lot of money and a huge design and that kind of thing to start working on loneliness. So circle one thing that you could do in the workplace to take action on loneliness, and there's a space down at the bottom. If none of the 6 things that we listed appeals to you, write your own. We'll take just a couple of minutes. Go ahead. Okay, 10 seconds more. Okay, let's move on. And if you didn't get enough time to really select something, I encourage you to keep that page. I asked them when we were creating this to make sure it fits in your little booklet, and they said, yep. They just fold it. It fits in your booklet. Don't lose it. Take action. And here's something I want to do for you. This is a little bit about mindfulness, which is really being intentional and putting ourselves in the right frame of mind. And I'm going to do it for you first, and then we're going to do it together. So, okay. May you be healthy. May you be happy. May you be strong. May you be prosperous. May you be productive, and may you be peaceful. Deep breath. Let's do it together now. This time, and you can do this in different ways. And I did that with my department one time, and they are spontaneously kind of using it at the beginning of some meetings. So I happened to be in a meeting that was being led by one of my staff, and she said, let's take them, and we call them be well moments. Let's do a be well moment, and she did this. And it was just nice. It takes 1 minute. Okay, we're gonna do this, the we. So read along with me. May we be healthy. May we be happy. May we be strong. May we be prosperous. May we be productive. May we be peaceful. That's the wish that I have for you. And I did put the little copyright symbol up there. I made up mindfulness, kindfulness. You will not find that anywhere else. So that's me talking to you. So finally, this is my last point. The last point is social connections are so very important to health, well-being, and productivity on the job. So what is the difference between illness and wellness? Anybody got an idea? In illness, we're looking at the individual, the I. In wellness, we focus on the we. The social connection is so powerful. So now I have 2 minutes, so I can take 2 or 3 questions. And there's a little mic here if anybody has a question for me or a comment. Oh, come on, please. I worked really hard. Somebody asked something.
What have you seen as kind of a surprising or creative approach? What's have you found as kind of a surprising or creative approach that you wouldn't have thought of that turned out to be really kind of a pleasant, or it surprised you?
Yeah, thank you, thank you. You know, it was that one where they had workers at this bottling factory divide them into givers and receivers and controls. And I was startled at how powerful it was that both the people giving kindnesses off of a list to that the receivers made, and they shared that, how it made those receivers feel better, but it also prompted them to be kind to other people, which was not part of the experiment. And the controls didn't change a thing. So I think sometimes it's the intentionality and kind of getting a thought out there and how people will pick up on this. I think that we in the U.S. are kind of craving this. And it shows in a lot of the data that I read. I think it doesn't take much to give people like permission. They don't need permission, but they need an idea. So it might be the Unlonely Project, or it might be something about random acts of kindness, or something about attitude of gratitude, or, you know, there's a lot of things out there. But the things are there because we're craving it. Another question, yeah?
How would you, I work with employer groups a lot. How would you suggest an employer group starts in this process? Because, you know, if you start with too much, it's overwhelming.
Yep.
So, did everybody hear me on that?
Yeah, how do you start in the process?
Okay, I'm sorry.
So how would an employer group start in the
Get
process?
started,
Not
right.
overwhelm the employees and not make it like flavor of the month,
Right.
that kind of thing. I think you could add on to some things you're already doing. So for instance, there are a lot of employers that support, you know, getting, especially when the weather's nice, getting out there and taking a little walk instead of a break, or use your lunch hour to walk. I wonder whether having a sign-up sheet for people who want to work at from 10 to 10:15, let people sign up and gather at a place, and they might meet other people that aren't in their immediate network. And people, they don't even have to be told to talk. They will just chat a little bit about the weather or about the landscaping or something, or just introduce themselves and say, I've got 3 kids or whatever. So you could be a little bit stealthy, and I think it still would work. That's an idea that I'm promulgating at HealthPartners, and I need to talk to our senior VP of HR, but I think she might like it. Other questions? Yeah.
I just want a follow-up. A follow-up to that. Would you suggest that adding, a lot of employers have wellness committees. Would you suggest adding this initiative to a wellness committee or to having a separate committee?
I would say wellness committee. This is about health and well-being. That's the way that I took this whole body to our Be Well steering committee, which I sit on. And I kind of worked up what we were going to do with the Unlonely Project to start those conversations. But I went through that door. I think it's important not to make it different. It's all about health and well-being. So I think it should be on their agenda. How many people are, oh, go ahead.
I was going to say, I know you mentioned on a slide earlier that, you know, the happy hours and the whatever are not necessarily the things for social events. So, and I will say, people of a certain age, meaning me, there was a point in time when at work we were very social and almost told to shut up and do your work. Now the younger ones come in, they come into work, they shove their earbuds in their ear and they sit down and they don't talk to anybody. They could be working on their phones and whatever and talking to people, but what would you suggest to encourage more camaraderie to come back into the office?
Well, I think we have so many people that work from home, so they don't see each other. I do see there's a generational difference in that how we connect, maybe not that we connect. But I suspect in some of those, it's like the Harvard Business Review. They look like they're just doing work, but they're actually showing kids' pictures and cat pictures and stuff is going on. But I think that it doesn't help some people who are more shy or reserved, and those are the ones that I worry about. The outgoing people, they're probably going to be fine whether you do something or not, but there's going to be somebody on most every team, and sometimes several people, that feel like they're shut out. They're not in the inner group, not in the clique. Those are the people that I think you need to set up some things. Like, I liked Vivek Murthy's idea of having 5 minutes at the beginning of some meetings to share what's meaningful for you. You know, here's a vacation I want to take, here's one I took, there's my cat. I think little things like that that aren't threatening, because shy people, well, they're not so engaged because they're shy. And we don't want to like pair a gregarious person with a shy person for a coffee, because the shy person is going to be overwhelmed real fast. So we want to do it in subtle ways and in opportunities where they get to have control. And that's why I like that show me a picture that means something to you. And let them know in advance, because somebody did that with me at church. I could not find my horse picture. You know, it's like going through 10,000 pictures. So that's the other thing is like, we're going to do this on Mondays, that kind of thing. Any other questions or comments? How many people are going to do something with this lonely stuff? 1, 2, 3, 4, 5, 6, 7, 8. Okay, who's not going to do anything with this? They're just like walking away. Raise your hand. Okay, thank you very much.
Thank you, Karen. Did anybody guess what her mysterious issue was in public health before she presented? Okay, did she keep the secret? Awesome. So our next topic is a very, it's another one that's ripped from the headlines, pain and opioids. Dr. Brett Hockey has joined us today. Brett is a board-certified neurologist. He's also the chief medical officer at Regions Hospital in St. Paul. He will share how to live your best life and make positive changes even when dealing with chronic pain. Brett will share how different ways to manage pain without medicine, which is one of our efforts to reduce opioid misuse across our membership. Brett.
Thank you. Thanks for having me here today, and thank you for that nice introduction. And I'm pleased to be here in Fargo doing this talk. Most of you in this room probably don't know this, but I lived in Fargo from '95 to 2007, and I'm always, well, it's actually a mixed bag to come back, because when my wife and I and family loved it here, all 4 of my kids were born here, and it's sometimes very sad because I didn't really anticipate leaving, but been in the cities now since 2007, and happy to be back to talk about this very important topic to you today. Also, I have not heard Karen give that talk before, and I do think that there's some co-learning we could do together, because when somebody has an accident or somebody has pain, and we're going to talk a little bit about why people have pain, but what predicts that pain persisting is not the severity of the accident. This pain persists for other reasons. And those other reasons include the kind of health care they receive, the kind of pills they receive, their confidence that they can get better, how strong their relationships are with others, how well they're willing to exercise. And there's lots of other things that affect wellness. And so maybe I'll tie that in with a study that was done once that looked at people that had chronic pain, and they did PET scans of their brains. And a PET scan is like an MRI scan, but it shows the brain in different colors. And those different colors show up based on the amount of glucose metabolism in the area. And so when people are in chronic pain, you can see redness in the thalamus. The thalamus is the part of the brain that carries the pain fibers. If the patient says, I'm okay, I'm going to be better, even if they don't believe it, the redness in the thalamus decreases. And so the power of positive thought is extremely important when it comes to pain. And you'll see that a little bit as these slides play out. So most people are aware of Prince's death and the fact that he died of an opioid overdose. I think his story is not indifferent than what we see in clinic. I'm a neurologist and see a lot of people in clinic that are in pain. And maybe to tie it into the Fargo experience, there were times when I was here where we were fairly understaffed as it relates to neurosurgeons or pain clinic opportunities. And so I saw a ton of patients with pain and was able to see how people responded to pain in different kinds of therapies. So people come into clinic. Prince came into clinic not because he was a drug abuser or even was predisposed to drug abuse. He had a bad hip. He had his hip operated on. He was given pain pills for the hip operation. His pain pill use escalated until he started to buy illicit drugs, and then he received illicit drugs laced with fentanyl, and he died of an overdose. And that's a fairly similar story to many of the patients we see in clinic that have chronic pain, hopefully not with that outcome, but that outcome unfortunately happens more often than I think most people recognize. So first, I want to point out what opioids are, because not everybody can recognize the name of an opioid if they see one. But opioids are prescription medications given for pain, and the list of them are here. I see that we squished our slides a little bit and some of the letters fell off. But opioids are derived from the opioid poppy or other chemistry parallels to that compound. So the opioid poppy makes a protein called opium. And that opium, you probably are aware of, has been used for centuries for pain in all sorts of countries across the world. And then we've looked at that opium compound and made other derivatives. It just so happens that that same compound is made in our own brains, and our own brains use that compound to decrease pain. And so when we give people exogenous or opioids that are outside of the body into the body immediately reacts to those opioids. And that is manifested by a decrease in pain. But it's also manifested by an immediate response by the body to try to re-experience that pain. So after a single dose of opioids, you can see changes at nerve endings that ramp up their perception to try to retell you that you've been injured. So we'll look at a couple slides that show the manifestations or what happens because of that. But what I want to point out here is that opium, heroin, are no different in their chemistry makeup than these things that are in pill form. And if people understood that the pills they're getting are little pill forms of heroin or opium, I think it would affect a little bit about the way we think about taking those medications. And it should affect it. The medications are highly addictive, and they immediately change the way we react to pain. Now I want to point out another point here, which is Ultram and Tramadol. This is widely distributed as kind of a gentler, kinder, non-opioid type pain reliever. That really isn't true. In fact, of all these prescription medications on the list, the Ultram or Tramadol is the one that most often ultimately leads to heroin use. And so it is not a gentler, kinder medication. It is just boxed in a different way that doesn't give a person the same kind of high, but actually leads to some of the other addiction potential. So opioids block natural pain. So if I injure myself, but I'm in a sporting event and I want to get back in there and keep playing, I suck it up and I don't cry and I get out there and I don't tell my coach I'm hurt and I keep playing. If I'm injured at home and I got a good audience, I might start bawling like a baby, and the reality of it hurts a lot more. But think about all the times you're cut and you don't know you're cut, you look at the cut, and then all of a sudden you feel the pain. And so your body has an amazing way to modulate the way you experience pain. So for every fiber that comes to your brain to tell you you're experiencing pain, you have 200 fibers that come down and can modulate that pain response. And so the most severe story I've heard in this area is that I knew a gentleman who fought in Vietnam. And he was out at the front lines, and his captain went out in front, and his captain got shot and fell down. He ran out to his captain, grabbed his captain, pulled him back behind the lines to safety, and brought him to the medic. Puts his captain down, looks at it, and he's got blood all over the front of him. And then he realizes he was shot 5 times. He had no idea that he was shot until he recognized the bullet holes. Now, this manifests in other simpler ways. I, for one, am not a person who likes to swim in cold water. And frankly, I don't like to swim even in 70-degree water because it's too cold for me. I'm just really kind of hypersensitive. But when my kid falls off the end of the dock, I don't care if it's 34-degree water. I don't feel that water as I snatch my child and put him back on shore. And I think we've all experienced that. I mean, it could even be as simple as if I pull my dock in and out at the end of the year. I trudge right in there and grab my dock and pull it in, whereas if my kid wants me to swim in 48-degree water, it's like, no way. But so you actually can modulate the way you experience pain quite simply. So I'm going to jump ahead here and show you a graph that's a little bit complicated. So this graph represents an experiment with animals, but it is absolutely true in humans as well. When you give a dose of an opioid painkiller, you immediately get pain relief and it lasts for 4 to 6 hours. But when the pain pill wears off, because of the way your receptors and your neurons have already started to potentiate or ramp up your experience, you get a tail of 96 hours of increased pain. So you actually get worse pain after the opioid wears off than you had before you took the opioid pill. Now think about how this manifests. So a person, if they're not fearful of taking the opioid and they're following their physician's directions, they take a second pill and a third pill and a fourth pill and a fifth pill and a sixth pill and a seventh pill. And with every pill, the pill works less well. And the tail of hyperalgesia gets longer and longer and longer till they try to self-discontinue the opioid and their pain gets so severe, they go back on it again. Now, this manifests in lots of different ways. We can see people, we've done experiments now where if we give an opioid during an operation, they will require more opioids during their hospital stay than if we don't give an opioid during an operation. So this whole piece of the opioid story was widely misunderstood for decades and still is misunderstood when you hear people say, you're not listening to me, these opioid pills help so much. They do help as an individual dose, but they actually worsen the pain over time. Now, if you're healing from an injury and you're healing faster than this opioid potentiation is setting up, you might just self-discontinue the opioids and go on your way. But if you got a severe injury, or if you really believe you shouldn't experience any pain at all, you can see how this opioid potentiation can lead to increased opioid dose until the next thing you know, you're addicted or habituated to the pills. Now, mind you, opioids have a very important role in medicine in certain categories. For burn patients, they can't survive burn without opioids. It's just so horrible and traumatic. Major tissue injury, major surgeries. It's made a lot of surgeries possible. At end of life, we certainly don't want people to suffer. Opioid pills can be very helpful in those scenarios. But for people that are just trying to treat run-of-the-mill pain, or even for middle-of-the-road injuries, we really should avoid the opioid pills altogether. So what happens if we don't avoid the opioids? So I think I'm backing up. Okay. Oh, I want to mention maybe one other thing. So not only does the opioid pills, I want to go back one more, make you not feel pain, but it also disconnects you from psychic pain. So psychic pain is that discomfort you feel when your kid's not doing well in school, the feel when you aren't getting along with your spouse, when work isn't going well, that stuff that kind of keeps you up in the middle of the night. Opioid pills actually disconnect you from that, so it just doesn't bother you. And so opioid pills are extremely alluring and extremely hard to get off, particularly when they're mingled with depression and anxiety, post-traumatic stress, and other mental health disorders because of this psychic pain component. So this is kind of my shock and awe slide, but in America today, 5% of every man, woman, and child are on opioids every day. 1 out of 20 people. There's enough opioids prescribed in the United States today so every man, woman, and child could have an opioid pill every 4 hours for a month. The amount of opioids prescribed since 1990 have gone up 600% every decade, and the amount of opioid-related deaths have gone up 300% every decade, to the point now where 70,000 people are dying each year of opioid-related deaths. That's more deaths each year than Americans died in Vietnam. It's a really, really, really big deal. The reason this is 20,000 deaths down here is that this is people just dying from their prescription opioids, thinking they're taking their pills as prescribed, not to mention the 50,000 additional people where it's gotten out of control and died deaths like Prince did. Okay, so the other thing this slide reminds me to describe is that in the last 3 years, we have bent the curve because of the opioid epidemic and the publicity. People started to prescribe less opioids. But it's not as simple as just telling someone who's on opioids every day that we're not going to prescribe them anymore. Because if we take that route, it is very difficult for those patients, and those patients will find other ways to get opioid pills, and that sometimes includes buying pills on the street. Sometimes that leads to heroin use. Sometimes that leads to getting pills laced with fentanyl. And so while we have decreased the amount of opioids prescribed in the last 3 years, the amount of people dying of opioid-related deaths have gone up. So we have to be able to give appropriate addiction care for people that are on opioids every day, or help people get off them if they're on them every day. So how did we get here? So in the late 80s, there was a group of physicians in New York that were cancer physicians. They were aware of people dying deaths from metastatic cancer that had a lot of pain. And they thought that was not fair, wasn't right. And I think they're absolutely correct in their assumption that that wasn't right. They were aware that opioid pills could help relieve that pain, allowing people to die with dignity and to have less pain. And they went out and they raised their hands and they said, we need to be more aware, more conscientious of these patients dying in pain. We need to liberalize our ability to prescribe opioids, and don't be so fearful of it when people are dying. Then some people took that and generalized it a little further. And they said, well, this is America, 1980 something, we've got the greatest healthcare system in the world, is what people thought then. And they said, why should we not allow all of our people to not have pain? Why don't we give people opioids to relieve their pain no matter what their pain is from? And then someone wrote an editorial in a journal, and the editorial said that the risk of opioids addiction is much less than people think. And in his experience, when we provide opioids for pain, the risk of addiction is really, really quite low. And that actually became the literature to support a story that it's safe to use opioids. Let's be more compassionate. The risk of addiction is much less than we thought. Physicians are supposed to relieve pain. Why don't we provide people the opioids they need to decrease their pain? The pharmaceutical industry immediately realized that this was an opportunity to increase their sales, and they went on a huge marketing campaign. And then the pain societies started to release papers that said that people are actually incompetent or are not doing good health care if they don't relieve pain. So relieving pain became the 5th vital sign. And then the Center for Disease Control, or CMS actually, started to change the way they pay physicians, whether they actually relieved pain or not. So if we didn't ask about pain, didn't relieve pain, they would pay us less money. All of that converged to this epidemic of overprescribing of opioids. So prior to 1990, and if you look at most other countries in the world, the risk of opioid addiction is about 0.5%. So that's a combination of a genetic predisposition, someone who has the availability of things like heroin, who's a little bit of a risk taker, who, all those things converge to create this 0.5% risk of addiction. But in America today, with this influx of pills being dumped on the community and people sometimes following their physician's advice, 5%, so 10 times more. So when people say, what's the opportunity for us to decrease opioids in our community, the opportunity is actually a 90% reduction in opioids. It's not 30%, it's not 10%, it's much more than what we think it should be. Now, I want to mention that, so the New York article talks about the marketing campaign, this pain management glossy. Every month that I've been in practice since 1995, I've gotten a glossy across my desk that tells me that I'm not treating pain adequately enough and tells me about the next greatest opioid that I should be using. I always had a little streak of paranoia and would turn that magazine over, and it was always supported and produced by the pharmaceutical company, and every author was being paid by the pharmaceutical company. And so that's the kind of stuff that was going across physicians' desks for 25 years. Okay, so when I first went to HealthPartners in 2007, I had seen enough, I had experienced enough, I had no longer could keep my mouth shut that I thought we were going the wrong direction as it was related to the way we treated pain and the way that we used opioids. And at HealthPartners, where we have a platform for the fact that if we give people idealized care, it actually costs us less. The health insurance plan can do a little bit better. It's an integrated system that we can all benefit from doing the right thing. It gave me the platform to be able to say we need to stop this craziness. So I met with one of the primary care doctors in our system, who was a person who went around talking about opioids and pain relief. And I challenged him on his beliefs, and I said, how quickly does it take for a person who's given opioid prescriptions to become habituated, which means that they're at risk of taking pills every day? And I don't want to explain the difference between habituation and addiction, but habituation is that they can't get off the pills without some withdrawal. Addiction is where they start to develop aberrant behavior. In my mind, it's so blurred and so intertwined that it's really, really tough to make the difference. The reality of it is it's just a spectrum of using opioids every day. But I said, how long does it take before people become habituated? He gave me a response that, interestingly, if you look at the Purdue pharmaceutical marketing, it was like verbatim out of their marketing. He said, well, if a person takes opioids every day for 6 weeks, then they become habituated, but that's not really addiction. It's only addiction if they start to have aberrant behavior, but addiction doesn't mean their pain isn't being relieved, and it's only addiction that we need to worry about. And I'm like, stop. And I said, I think this happens in a day. I maybe said 2 days. And he said, wow, Brett, that's really weird. Why do you, that can't be true. And I said, think for a second what happens. And you guys can play this mental game with me here today, because I bet you everybody in this room has been given a prescription of opioids in their life. So what happens when a person is given a prescription of opioids? There's a subset of people that say, I don't want that prescription. It scares me and I don't want it. There's another subset of people that say, okay, give me the prescription, just in case I'm in trouble this weekend, but they don't fill it. There's another subset of people that fill the pills, put them in their cupboard, and don't take them. There's another subset of people that fill the pills, take one pill, don't like the way it makes them feel, and don't take anymore. There's another subset of people that take a second pill, makes them feel bad, they put them away, they don't take anymore. And then there's a subset of people that take every pill in the bottle. The people that take every pill in the bottle oftentimes have a lot of pain when they put down that last pill, and they will oftentimes ask for a second pill. And those are the people that are at risk for addiction. So I said, I think that it gets set up right away because it's the people that continue on their pills. So he said, well, how often do you think that happens? And I said, well, I think it happens 10% of the time. And he said, why do you think it happens 10% of the time? And I said, because if you look in the burn clinic, 90% of the people are off opioids when their last wound heals, but 10% of the people aren't. If you look in the orthopedic clinic, 90% of the people respond to their knee and hip surgery without any problem, but 10% of the people are on opioids every day. If you look into these clinics, it feels like it's about 1 out of 10. Well, feel like is different than a study, right? They finally did the study and it was released in 2017, where the Center for Medicare and Disease looked at everybody on the Medicare rolls, and they looked at people that had not been prescribed an opioid for a year, and then they got a single prescription, and then they checked them a year later, and they found out that 7.5% of those people were on opioids every day after a single prescription of opioids. If they got a second prescription, it was 15%, and if they got a big prescription with a lot of pills, it was 30%. Now, think for a second about what happens to the people that don't take their pills, and they leave them in the cupboard. I challenge you to go home and look at the pills that you think are in your cupboard. 50% of you will find that they aren't there. They're being stolen by real estate agents, by babysitters, by friends of the family, by your kids' friends, by people that are just visiting your house. People are raiding people's cupboards for these pills. And so what happens? So then there was a study done that confirmed that 83% of pills go unused, and there was another study done looking at the red bars here that out of all the pills used in the community, only 20% of the pills are actually used by the person who they're prescribed for. The other 80% spill over. So the pills that are spilling over into fish bowls at high school kids' parties. And I don't think you've had this problem in North Dakota yet. But there are several communities in the Twin Cities where all of a sudden there's a rash of deaths of high school kids from heroin overdoses. And it all started with this overflow of pills into fish bowls at high school parties. It's a really, really, really big deal. Now, I'll go a little bit further and say that the number one way that opioids show up in teenagers' parties is through wisdom tooth removal. And so there was a big study, and there's actually a slide here, and I'm not going to jump ahead to it, but that looked at all of the comparison trials that have ever been done. They looked at Tylenol versus ibuprofen, ibuprofen versus Aleve, ibuprofen versus Percocet, Percocet versus hydrocodone, and looked at all the comparative trials that have ever been done. The bulk of the trials have been done in wisdom tooth removal. Some of them were broken bones and other minor injuries. They weren't major traumas. Out of these hundreds of thousands of patients that have gone through these trials, ibuprofen and Tylenol together work 20% better than any opioid combination, with better anti-inflammatory response, without the risk of the addiction. So I'll give you 3 stories that bring this point home. So one is that after one of these talks, a woman walked up to me and she said, "I'm so glad you brought up that wisdom tooth thing." She said, "My best friend has 2 kids. One kid had their wisdom tooth removed, got 30 hydrocodone, got addicted to opioids, died of a heroin overdose. My next kid comes in, gets her wisdom teeth removed. The dentist says, 'Here's 30 pills of hydrocodone.' Mom says, 'No way.' And the dentist says, 'Oh, good luck with that.' She didn't take the opioid pills. Kid does just fine, got through it without difficulty." About the same time, she's 21 now, but she was 19 years old. She had 4 of her wisdom teeth removed, really impacted, without making a big hullabaloo about it. We gave her ibuprofen plus Tylenol. She got through it just fine, without any great difficulties. Last story, so I was out moving a boat trailer. Was in a flower bed at a place that's 100 years old, and this flower bed has to be 100 years old. And a board had fallen open with 2 5-inch nails sticking up in the air. So I grabbed my boat trailer, lift it up, plant my foot, soft-soled shoes, and just thump. Those 2 nails just about came through the top of my foot. And so in about a millisecond, I made a decision, put my foot down, and thump, pulled my foot off of those nails. I go into my cabin and I wash my foot. It looks surprisingly good. Put a little bacitracin on it, a couple of Band-Aids, and I went on my way. And I was selling my boat trailer that day, so I sold the boat trailer and drove by a kind of a rural hospital and thought about going in, and I decided not to. That night, my foot was 10 out of 10 pain. I'm telling you, it was just like it was going to blow up. I took ibuprofen alone, not ibuprofen plus Tylenol. Within a half hour, I fell asleep. It really wasn't very bad. It was amazing how effective those medications are when you're not already in this slope of being exposed to opioids where your pain is accelerated. Okay, so I'm going to tell you a story about how one can approach pain differently, and it illustrates a lot of what I'm discussing. So I met a gentleman who, this is a few years ago now, who came to me with 7 years of neck pain. He was on 30 milligrams of OxyContin 3 times a day and hydrocodone 10 milligrams every 4 to 6 hours for 130 milliequivalents of morphine a day. Don't worry about the numbers, but it's a big dose of medications. He was married, has 2 kids. He was kind of a vice president type of a company, had a wonderful job for years, now was not working for 2.5 years, was in 10 out of 10 pain every day. Had 3 surgical opinions as to how they should fix his neck, and came to me to say, I've 10 out of 10 pain every day, what should I do to fix my neck? So I take a history, do an examination, dig under the hood. This is not an indifferent story to what I see every week if I'm seeing new patients. Literally, I will see a patient like this every week with the same general story. 7 years previously, he had been lifting some stuff, developed some pain in his neck, had some pain down his arm, undoubtedly ruptured a disc, and had a radiculopathy or a pinched nerve in his neck. He went to his doctor. His doctor gave him pills to decrease his pain. The pain persisted, and he underwent a minor procedure, a neck surgery to open up the canal around the nerve pinched in his arm. The pain down his arm went away. He had a perfect surgical outcome with nice alignment. And but after surgery, someone asked him if he still had pain. He said, "Yeah, I still have pain." So they gave him opioid pills to relieve the pain, and his opioid use escalated over time. And you can already tell, why this would happen based on what I've told you. So I read through his stuff. I know exactly what his problem is. I know exactly what he needs done. I look him in the eyes, and I tell him that that he does not need surgery on his neck, and that we need to go a different direction with his pain. I recognize that what I'm telling him that day is very different than what he's heard from physicians before, and there's no way in that single visit that I'm going to be able to convince him that in fact he needs a different path. I explained to him this opioid issue. I explained to him that the only way he's actually going to get off his pain, get rid of his pain, is to get off opioids. I explained to him the importance of exercise and other things. And I tell him a couple things that I haven't mentioned here yet. One is that as he weans the opioids, he will have more pain every day. The second thing is that when he's done with his opioids, it takes 6 to 8 weeks before his brain starts to make endorphins again. So he'll have a really long piece of suffering before he starts to get better. In fact, when we look at brain scans, these PET scans again, of people that are on opioids, they don't make endorphins or dopamine compounds or opioid-like compounds. It takes even a year later, they aren't fully up to speed. So I describe all this for him. I explain to him that this is the path that he's going to need to go to in order to get better. I asked him a couple questions I ask all my patients. Is I say, do you think you need the opioids? And he says, absolutely, which is a paradox because he has 10 out of 10 pain every day. Second thing I ask him is I say, are you better now than you were a year ago? 100% of these patients say, no, I'm worse. And they are worse because of this pain potentiation on the opioids. So I describe for him what he needs to do. I say to him, now I know this is tough for you to take this all in today. I want you to know I'm just one doctor out of thousands. You can walk out of here today and you can say, boy, that doctor was crazy. But I want you to know I'm a really good doctor and that I'm really confident that this is going to help you. I want you to take your plan and put it in your bedside table. And then I want you to, a month from now, 3 months from now, a year from now, if you're not doing well, I want you to take this out because this is actually how you're going to have less pain. So he went away. His wife was there with him. He comes back in 3 months. Unbeknownst to me, he took my advice very seriously, checked himself into a center where they wean opioids quite quickly. He comes back to me about 4 weeks off of opioids. I'm thrilled to death that he's made this progress. He doesn't look very good. He's in a significant amount of pain. I reinforce for him that he's absolutely doing the right thing, that he's on the right path, that it's going to get better. He hasn't started rehab yet. I put him into an exercise program. He's having some trouble sleeping at night. I help him with sleep at night. I look at his wife and say, how is he doing? His wife says, well, you know what? He's more engaged with his kids, with our kids. I know he's doing better, so I reinforce that. He comes back 3 months later, his pain's a 7 out of 10. Wondering if he can go back to work. Comes back 3 months later, his pain's a 4 out of 10. Comes back 18 months later, 0 out of 10 pain, bench pressing 245 pounds, golfing 2 rounds of golf a week, back at work full time. And I'm telling you that this happens all the time. Now, he has a good family, has good support, good insurance, good job to go back to. A lot of people don't have those things. He didn't develop aberrant addictive behavior. It's crystal clear to me, having done this now for a while, that patients who are really struggling with coming off, they need to go very slowly. Sometimes we need to use what we call medical assisted therapy, where we keep them on a stable dose of opioid a really long time, where we slowly wean it if we can. But to get rid of the pain, this is actually the right course. And a lot of these patients with kind of passive personalities that have just gotten addicted because their doctors gave them pills can actually come off of the medication. A lot of the patients that have kind of like street heroin, they need the medical assisted therapy. So I can't emphasize enough how much confidence and reassurance, positive language help people get better. And tying that into Karen's discussion, I think you can understand why that matters. Exercise absolutely matters. People make more dopamine compounds, they make more endorphins, their opioid circuitry is much better, and not using opioids makes a big difference. I want to point out that many people will say, well, my injury is worse. And I touched on this right at the beginning. These are slides. I don't have to demonstrate what's going on here, but you can see significant degenerative changes in these spines. They look really bad. None of these people had back or neck pain. These were personal patients that I saw that I got these images for different things, like clumsy feet or a numb hand. None of them did I get an image for pain. And they had some of the worst looking spines I've ever seen. So when I was training in residency, I did a moonlighting job at the VA. And the moonlighting job was that I needed to determine if patients were service connected. So they didn't need to prove that they had disability. They needed to prove to me that they had been injured in the service. If they had been injured in the service, they got free health care and they got some benefits related to the VA system. So they would come in to me and they would bring me a story as to something that happened in the service. And if they had good documentation that it happened and I could validate that the injury occurred, I'd just check the box that they were service connected. So I saw a woman who was moving eggs in a kitchen and developed back pain and spasm and pain down her leg and undoubtedly had ruptured a disc. I'm seeing her 20 years after the fact. She's on opioids every day. She's in chronic 10 out of 10 pain, hasn't worked in 20 years. Her imaging looks normal because the disc is no longer bulging. It's no longer pinching the nerve. I didn't need to treat her. I just needed to check the box that she had indeed hurt herself during the service. The next patient I see is a 78-year-old gentleman, and this is circa 1992 if you're adding up the dates to see if this works. He was a 78-year-old gentleman who was a World War II vet who had been a parachute jumper, jumped out of an airplane. His parachute didn't open completely. He broke both femurs, his pelvis, and 7 vertebrae. So now I'm seeing him 50 years later. His back was this gnarled mess of calcium and misalignment and just horrible looking. He had 0 pain, was a farmer, raised 5 kids, full life. So I said to him, I don't understand this. I said, the last person I saw had a very minor injury, chronic pain, 10 out of 10 pain, opioids every day. You have the worst injury I've ever seen in my life. You're on no medications whatsoever. You raised 5 kids and you farmed your whole life. He said, Doc, I'd be a liar if I said I didn't have pain after the injury. He said, I spent a year in the service, a year in the hospital. After I got home, I was so glad to be alive. I quit taking my pills. I quit going to the doctor and I got back to work. And so I posit to you that positive thought, exercise, an engaged community makes a huge difference in the healing process. So multiple different societies now, in fact, 100% of the societies have said that the benefit of opioid is far outweighed by all the deficits. It's a pet peeve of mine that people will say, well, if other things fail, well, then I'll get the opioids. No, the opioids don't work. They make things worse over time. They aren't a secondary rescue medication for these problems. The gentleman who first started the opioid campaign in the late 80s, Dr. Portnoy, wrote an article in the Wall Street Journal a few years ago where he says, I was wrong. I'm sorry that I was complicit in this, and he underscored all of the amount of pharmaceutical money that rushed into these discussions. As you saw next door at HealthPartners, we're very committed to doing right by our patients to decrease their pain and improve their health while we improve affordability and other things. But we've been doing lots of stuff related to opioids, and I'm going to highlight just a few. But we've changed, well, I've given this talk 100 times, including 75 physician groups. And so we're out in front of the physicians every day trying to change the way they prescribe. We're changing the way that we're putting limits in on a first prescription where we only give 10 pills if it's going to be prescribed at all. We avoid second prescriptions. We're finding the optimum amount of pills after surgery. Many of the surgeries we're just going with 0 pills. Our health plan is making interventions by looking at prescribers that aren't in our medical group. We've decreased 5.4 million pills prescribed in the last 2 years. The health plan interventions in other providers, not in the HealthPartners medical group, have decreased an additional 4.4 million pills in 1 year. We have pain clinics now that really look at people holistically. They basically work on weaning them off their opioids. If they can't wean off, they have them seen by an addiction specialist. We get them into a pain physical therapist. We have a pain psychologist that deals with them as we start to